Good morning, everyone. Welcome to our 9th reimbursement update for 2023 Drugs and Devices webinar, a famous webinar. But anyway, so I'm here today with me, Sarah Griffin from MedTechnique Consulting, and George Papadopoulos from Lucid Health Consulting. For housekeeping, just put your if you have any questions or anything, please enter them in the chat, and we'll deal with all the questions at the end. And we'll also make the slides available and a copy of a recording of the webinar available on our LinkedIn sites and websites. So we'll cruise through this. So let's get going. Sorry, just having trouble moving the slides. So for those of you who may not be in Australia, just really quickly, Australia has a universal healthcare system. It covers all our citizens, and about half of all Australians also have private health insurance. But private health insurance is really just limited to hospital admissions and ancillary cover such as physio and dentistry, and it doesn't include primary care and pharmaceutical. So as a result, we have a bit of a strange mix of public and private hospital systems, and it can be quite fragmented, and quite often there's lots of perverse incentives. So we have a funny thing. The way medical technologies work in private hospitals is we have a medical benefits schedule, which is a list of medical procedures covered by our Medicare system. And for a procedure must be included on the MBS to be covered by private health insurance. And we have this other weird thing that used to be called the prostheses list, but now called the prescribed list. And it's a list of mainly implantable devices such as hips and pacemakers, etc., that will receive a payment over and above any reimbursement for that admission. And consequently, devices that are not implanted in the private system are at a bit of a disadvantage. So politics 2023, not nearly as eventful as last year, which was an election year, but this first term Labor government has done some reforms around the edges to our Medicare system, mainly trying to increase access to primary care for general practitioners. So they've tripled what they call the incentive for GPs to bulk bill, which in real terms mean that people can go to a general practitioner without being billed. And also to relieve pressure on public hospitals, there's been many urgent care clinics opened around the country, which is sort of a step up from a GP, but not an emergency room. And it's sort of yet to be determined how this is working out in terms of relieving pressure, but there's certainly many of them being opened across the country. There's also been I think it's about $75 million of grants to develop and implement new medical technologies. So I've had a look at the list of grants, and it's very diverse, a lot of digital health things. So it'll be interesting to see how they all develop and how they are funded going further. Also, a national one-stop shop to enable clinical trials and medical research to be assessed and managed in a single place, rather than the myriad of different regulatory regimes to manage clinical trials across the country. And what's particularly of interest to this webinar is the prostheses list reforms have been implemented or are in the process of being implemented. So I'll delve into the prostheses list a bit more. So some of you who heard my webinar, I think it was about 6 weeks ago on the prostheses list, some of this might be a bit repetitive, but it is the biggest thing in device reimbursement in the country this year. So the prostheses list was, the list of devices that private health insurers receive will pay a benefit for over and above the price of admission. It's been hugely controversial for many years, with health insurers claiming that medical device companies were paid way too much for devices, which has always been debatable, but nevertheless, there's been massive reforms implemented this year, basically to cut the price of these devices and to make the assessment process more rigorous and probably, hopefully, more reliable. So a new portal opened this year, the Health Products Portal, open for applications. There's been a price decrease, other than the other price decreases that have been happening over the last couple of years, for general use products. And when we say general use, we're talking about a lot of things that are used in multiple operations. So they might be endoscopic sutures, closure devices, some sorts of meshes and things like that. So these devices are eventually going to come on the list, but at the moment their price is just being decreased. There's a consultation paper on regrouping all the devices on the list, but that has been delayed because we are at 30th of November and there's no consultation paper. But we do believe that this is going to take about another 12 to 18 months to be implemented, because there's 9,000 products on the list, and it's more complicated than I think the department realised to simplify the organisation system of that list. So we do the first applications for the new portal on, they're meant to be, actually I think that's wrong, I think it might be January 12th, that January 12th or 14th, that'll be the deadline for the applications. And in July, all the general use products are scheduled to be removed, and there's a further price decrease for other products coming next year as well. One of the things I think has been incredibly disappointing, and I would regard as a broken promise from the government, that there's really, despite years of discussion, there's been no change in the ability to list non-implantable devices on the prescribed list, other than those currently included on Part C. There's enormous hurdles to try and do that. There is a pathway, but it's very difficult. So we might delve into what's changed. So instead of the prostheses list, which is a bit archaic, it's now called the prescribed list of medical devices and human tissue products, which does not have a good acronym at all. So we just still call it the PL. And the prostheses list advisory committee is now called the prescribed list of medical device and human tissue advisory committee, which is also a very awkward acronym. So I think it comes out as MTAC or something. But anyway, they're not good at acronyms. So the new platform, it's a health products portal, and it's intended to digitise and simplify, and I do say this in inverted commas, the process to track and pay and manage regulated and reimbursed health-related products and services. So basically, at the moment, the PBS applications online, the medical benefits schedules, MSAC applications have come online this year, and also the immunisation program. And it's not simpler. it's quite a lot more complicated, but it is digitised. So it's sort of half true, that claim. So for the PL, there's some new pathways. There's a tier 1 pathway, which is the easy pathway, and it's called the abbreviated pathway. And basically, it's meant for any product that's non-controversial, has a low TGA grade, 2B and below, and is really could be considered a Me Too product. So basically, these products won't have a clinical assessment by a clinical assessment group. The departmental staff will recommend or not recommend directly. However, for the department to verify that these products are indeed Me Too or of substantial similarity. They want lots and lots of information, which makes the application process quite complex. And there's a lot of extra information that can be quite difficult to get that is required. So the second pathway is called the clinical or focused HTA pathway. It's not as clear, but basically anything that has a TGA of class 3 must go through this pathway. And if it's basically a Me Too product but class 3, it's pretty similar to the current process that we have. Where it gets complicated if you want a higher benefit, or you're claiming superiority, or you want a new group, or there's 2 or more comparators with different benefits, it needs a much more focused assessment. So there will be a contracted health technology assessment if there are additional clinical or economic questions to be addressed. And since this is a new pathway and there's really been no specification as to how these additional clinical or economic questions are to be addressed, it's a bit of a minefield for applicants. But it won't be easy. So the third pathway is what they call full HTA pathway. So basically this is a referral to MSAC. And what the published guidance said is basically if there's not a medical service, if there's not an item already on the medical benefits schedule, then you have to go to MSAC. But you have to go to MSAC for that anyway, so that's a bit of a no-brainer. But also if the new prosthesis extends the range of indications or the population beyond the original intent of that MBS item number, that goes. Or if the new prosthesis is novel or breakthrough or first in class, so that's an awful lot of devices. Or if there's no suitable comparator on the PL, so you have to compare to a drug or a medical service. Or if it has likely to have a significant budget impact, or if you're claiming clinical superiority or improved quality of life. So to me, that looks like a whole bunch of things would go through the HTA pathway. But my recent experience is that that's not how if you're applying for Part C, that's not necessarily how that will happen. So there is a level of confusion with these new application processes. So just some of the implications of this new process, and I've skimmed over this because it's not appropriate to go into huge amounts of detail in this webinar, but if you go to MedTechnique Consulting at our website, there's a whole other webinar that goes right into the detail of the PL. So we can just look at it from a more superficial level here. So basically it's a sponsor's responsibility to nominate an appropriate pathway, which is really quite problematic because it's quite unclear. So I tell you, you'll have to try and engage with the department as much as you can to try and get guidance. And at present, there's no timelines of when each step in the process must be completed. So we don't know when the department's going to get back to us at each step. And the present process is very random. So we're anticipating that it might be a bit more predictable, but no one's given us information yet on when these different steps, basically when you hear a response to your application. The other thing is the information requirements, even for the abbreviated pathway, might be quite difficult to comply with. So you have to provide information on competitor devices, which may not be, or comparator devices, which may not be publicly available. And also you have to provide utilisation and prices of devices in other countries, which may be difficult to access, particularly if you happen to be a distributor and you don't have a parent company to get that information from. And also we're required now to search adverse events databases, both of your own product and sometimes of other products as well, which is quite burdensome and it's probably redundant as well, but we couldn't seem to talk the department out of it. And there is this assumption within the application process that the sponsors actually have control of market size and clinical use, because you have to talk about what sort of efforts you're putting in to keep the use of the device to the appropriate indication, which is a little bit out of sponsors' ability to deal with. So a big thing is it's all going to cost a lot more money. So I've taken this is the cost recovery impact statement. This is basically what the department thinks the costs they will incur for doing an application, and this is what we can expect to pay. So your bog standard abbreviated pathway is now $1,370, and it's a bit unclear if it's for every single rebate code. So for some systems, they might have lots of rebate codes. So there has been talk that you can apply for some sort of consideration if you're in that situation, but there's no real process for that as far as we know as yet, that you can apply. For a focused clinical assessment only, it's $5,500. A clinical and economic assessment is simple, and we haven't really, in the guide, they haven't really defined what simple is or complex is, but as you can see, it gets the fee up to about $14,500. For a complex assessment, the total goes up to $22,500, and other, which we really don't know what that is, up to $33,500. And the full HTA pathway, you have a clinical assessment with the PL group, and that comes to $4,760. And I've highlighted that in red because there may be a whole bunch of other costs if you get referred for a full HTA, but that's only the cost for the PL part of the process. I know that's a bit complex, but that's how the system works at the moment. So just some practical advice from my very early and very recent experience and incomplete experience is do your applications as early as you can, because the health products portal is really clunky and there's lots of glitches where you can just get stopped in your application process and you can't get any further until that glitch is resolved. You can only talk to the support people via email, and it can take a couple of days for them to respond to an email, and then they ask you for a screenshot, and it might be a day or so after that before it's resolved or not resolved. So this has happened to me. They'll usually give you a workaround, but be prepared. So you might get almost a week's delay in your application, so it's best to start early. And the secretariat, other than the IT support, is also slow to respond. So you just have to be persistent. And as I mentioned before, there appears to be some confusion about the more complex pathways. So I advise you to get advice, but it's quite difficult to get advice. It's only by email, so you just have to be persistent. And an interesting thing we learned at a training session a couple of weeks ago is the health products portal for the PL is only built to the application stage, and they haven't actually, when I say built, I'm not an IT person, but the assessment phase isn't working yet. So it'll be really interesting when that comes into, comes live, and there's all these assessments to be done and what glitches there may be and what delays. So I anticipate that there will probably be some difficulties next year during the assessment process. So Just an update on MSAC, the Medical Services Advisory Committee. There hasn't been a huge amount of change since last year, just pretty much more of the same. Though all the applications have moved to the health products portal since March this year, it's a moderately more complicated initial application, basically the same information, but just in different forms. But it functions, the MSAC application functions much, much better than the PL application. And we know that MSAC continues to have an extremely high evidence bar and very little tolerance for any uncertainty. And I would say, compared to other HTA agencies, say, for example, the NHS, or NICE, I should say, in the UK, there's very little pragmatism. It's a very ivory tower assessment. The applications are always assessed by contracted HTA agents, and our experience is that these are of variable quality. So some are very sensible, and others appear to be done by, maybe more inexperienced PhD students or something like that. So there's a high level of unpredictability of the outcomes of those assessments, which is, quite problematic because it's very difficult once these assessments are done to get them to change. But probably the biggest bit of advice we can give you is to get the support of your clinician groups on side before you apply. I think this is the biggest hurdle applicants face, and it's where applications can just be stopped in your tracks. So don't apply until you've got your colleges on side and your key clinician groups on side. So George is going to talk about this, but there is a review of health technology assessment and assessment policy and methods. That sounds like lots of fun, but it's basically to do with medicines policy and PBAC assessments, but it is a technical review of HTA methodology. And even though it's not meant to apply to devices, it is going to have huge ramifications for device assessment, because inevitably whatever happens in pharmaceuticals always crosses over to devices, however inappropriate or difficult that is to apply the same standards for the devices. So just be prepared for that. I know MTAA, while not invited to, has made a submission to this review to put the device side of the picture towards this review. And I understand that it's not a particularly open review or transparent, but I'm sure George will talk more about that. So political predictions for 2024. Not as exciting, not as exciting as last year. There's probably, I think it's unlikely there'll be much movement in PL policy for a while, which everyone will be quite grateful for. I think there will be some Medicare policy reform around access to primary care, maybe also around the edges, because it's incredibly difficult to change the National Health Act. But since there will be an election between August next year or May 25 the year after, I suspect there'll be some policy announcements around healthcare. You can see the way the policy is going with the urgent care centres and the increased subsidies for GPs. So there'll be more in that space. And I also predict that private health insurers will continue to lobby for further price decreases. But as I said, I think we're fairly safe for the moment. And that's my bit. So thank you. And I'm going to pass over to my learned colleague.
Thank you, Sarah. And I think we can see one question already in the question and answers, but we'll get to all the questions at the end, if you don't mind. So a deep breath. Thank you to everyone for logging back in for our ninth seminar. I'm not sure we'll make it to double digits, but we'll see how we go. We're getting tired and I'm getting old. All right. But just as Sarah had it at the beginning, just to set the scene of where the pharmaceutical side of the business sort of sits in healthcare, it's all under the Department of Health and Aged Care. And it's good to see that they haven't changed their department name again, which is nice. But I'm sure if we change governments, we'll get another change to that as well. But I'll try and get more serious. So everything's run by Medicare at the federal level, or reports into it, or it has responsibility for it. And Sarah's touched on the device side, which is mainly FBS. We're going to sort of talk a little bit more about on the PBS side. And Sarah also touched on the bottom right-hand side there, the private hospitals and health insurers. And we don't really go into too much about the public hospitals and the aged care, but the department definitely runs, the federal department definitely runs aged care and has joint responsibility for the public hospitals with the states and territories. So I think, as we said 8 times before, it's a somewhat fragmented system, still probably one of the best in the world, but with some perverse incentives which we deal with. I've just borrowed some slides from my colleague Steve Crowley, who works with us. He's put together some nice slides for another meeting about specifically around the reimbursement, our reimbursement system, and specifically the PBS, and how do we interact with the HTA, Health Technology Assessment and Pricing. It's a complex, somewhat complex slide, but as Kim and Sarah had mentioned, we'll be sharing slides afterwards, and there'll be a video on our respective websites as well, both MedTechnique and Lucid Health Consulting. So in the centre there is the PBS, which is the benefit scheme where the drugs are reimbursed. You do need a positive recommendation from the PBAC, which is on the left-hand side before you get there. And at the moment, approximately it's $14 billion Australian in expenditure, about $9 billion US. So the PBAC, it's really the submissions are evaluated by an academic centre, external evaluators, and then the PBAC's economic subcommittee. And in theory, the decision-making process looks at the clinical need and effectiveness, cost effectiveness, overall financial implications, and then uncertainty around that clinical and financial and economic evidence. We don't really have a formal price referencing system, but in a way we do, in the sense that if we're claiming non-inferiority and safety, we're basically doing a cost minimization analysis, which essentially means you're referencing to that least costly comparator. Increasingly, the PBAC has been considering risk-share agreements, and when I say recently or increasingly, they've been around a while, but they continue. And for people who are not familiar, usually covered under a deed of agreement between the companies and the Commonwealth Government. And then the bottom part of that slide just sort of goes through what your claim is going to be if you're doing a superiority, non-inferiority, or inferiority. What happens when the PBAC recommends it, form of analysis, and then the basis of the pricing. And so you can see, really, to get a price premium, for want of a better phrase, you really need to claim some type of superiority over your comparator in the system. So that's a quick snapshot overview of the PBS/PBAC system and getting the drugs onto the PBS. And then obviously a lot of people, well, companies, everyone's interested in the pricing of things. There's an evolution of pricing that's happened over the years on the PBS. We have had historically a very stable set of prices on the PBS. Once you go on, it's pretty stable until patent expiry. but we've seen it's been what we call dynamic pricing in the sense that it hasn't been stable the last few years. So prices do decrease over time. Again, I think, like I said last year, don't forget, you're always allowed to apply for price increases. And so it's often forgotten about because we're so caught up in the price decreases. But if you look at the graphed slide left to right, you know, we talked about that initial price setting, which is the PBAC, PBS process, about price negotiations and caps and budget caps and risk share agreements. Then effectively during your patent period, even though you do have the patent protection, you know, we as an industry agree to statutory price reductions, anniversary price reductions at 5, 10, 15 years on the PBS. And so you do find prices decreasing at those over those years. And then, of course, post-patent expiration with introduction of generics or biosimilars, you have a sort of a mandatory 25% price cut, but then through the process of price disclosure, they can tumble a lot further. So it's sort of what we would say dynamic pricing over a period of time on the pharmaceutical side, which is a little different to the MBS / medical services or PL. Although, as we discussed with the PL, and I forgot all those new acronyms, there has been a rash of price discounts and price decreases and taking products off the PL. And I know MSAC and it used to be CLAC. It's the MDAC. Stupid acronym. I think they always look to the PBAC to see, and that process to see what they can steal or take, including cost recovery, by the way, which we'll get to in a minute. Anyway, so that's kind of a bit overview, bring everybody up to speed for the new people on the call, maybe a bit of a revision for people who've come back to us. So I sort of took a little different tack to kind of break it up a little bit from previous presentations. And this was my summary slide at the end of last year to say what's moved, what hasn't moved. And I must say I was mildly surprised and shocked that there's all green ticks. I thought I was going to put red crosses, knowing the snail pace of policy making and the government moving. So you can see, you know, last year we sort of spoke a lot about post-market review, the agreement between various HTA bodies, national policy reviews out, efficient funding's out, and we'll talk a little bit more, like Sarah said too, about at that time last year when we were here, we only really had the reference committee for the health technology assessment review, policy and methods review. So we've moved on a little bit, but I think most of that's going to happen in 2024, which is even crazy that we're saying 2024 for someone born in the 60s. Anyway, I won't bore you with my geriatric meanings. Anyway, so if we go through, I'm just going to quickly run through the ones that have the green ticks, just to show that we do move along and we're not as stationary as we think. So national policy, national medicines policy was a lot of work, and it was delivered to the government, as it says there, refreshed policy December 2022, and sort of operated. It's in operation this year. I think the two key parts of that. That's one of my biker friends going past outside. In case you could hear it, it sounded like a Harley 1978 Softail, if I'm not mistaken. Anyway, you can see the two main things about the policy is the relationship between all the policy partners, and you can see the government's taken a big portion of. Importantly, that's not just about corporations, but it's about people, the carers, families, and the communities, and everybody plays a part in the collaboration and the cooperation. And really, the aim of the policy is to set a framework to make sure that Australians have fair, timely, reliable, affordable access to high-quality medicines and medicine services. So it underpins what we've been talking about, reimbursement for and timely access, which then feeds into the HTA review, which we'll get to. I'm not going to go through the whole part of the whole graph there. You'll have it there, but you can see there's lots of parts to it, and the aim is making partnerships work. So there's the central pillars in the middle, and there's 4 of them, like there were before. I'll just read them out quickly. It's medicines that are used correctly and safely. As I said, fair, timely access. Medicines are high quality, safe and effective, and that everybody works together to, to make sure that we have innovative and sustainable products, and that also our workforce is skilled to the appropriate level as well. Then the middle ring is the principles that underline those 4 pillars, and then obviously all the collaborators, what they're called enablers here in the policy, that has to work together. And I think that's the key thing about the National Medicines Policy, making those partnerships work, as they said there. So that was delivered 2023. I think it does underpin a lot of policy work, and it should underpin policy work going forward. So I think it was a good achievement to deliver it and make it. I think it's up to us as a collective to make it work and make those partnerships work. Oops, I think I missed one. Just give me a second because I am too quick. So there's not too much around this, but if you recall last year, there was a bit of I think a lot happening in the background. It's not very transparent, although I haven't put that on my slide, but I think that's the takeaway of the message here, that even though there's an international HTA collaboration, it's been expanding. So there's now 8 HTA technologies. So you can see them there. I'm not going to go through all the acronyms, but it's all the big ones you would expect, and including the French, which normally don't get included. Nothing to do with the French. But the collaboration, though, has met. I know that. I understand from various people and sources. They do have working groups. I think there's even a meeting in the US soon where they're all going to meet. It has 3 priority areas for 23 and 24. And the big areas, there's detail underneath this, but it's work sharing, science and methods development, and horizon scanning. I think big three ticket items if all of these agencies are collaborating. You'll notice in opposition or in conflict with the national policy that I just spoke about, it's not very collaborative because it looks like it's a closed group and they seem to be talking to themselves. So they're not really enabling and working together, at least from what I can see, whether it's with industry, patient groups, academics, and so forth. But interestingly, also, apart from these 3 priorities, these partners will continue to engage with the regulators of these countries. And so, especially where those regulators are already collaborating in some of and sharing work themselves. And the example is Project Orbis and Access Consortium. So there's this coalescence of collaboration, but it seems to be, I think, behind closed doors, at least from what I can see or I can tell, which is a little disappointing, I think. But I think it's one to watch out for in 2024 as we move forward into the new year. I think this one here we're not too heavily involved with. It was a big review of the efficient funding of chemotherapy. It's one of the pillars of the PBS as well. A lot of issues around vial sharing and pricing and cost. The recommendation was completed, or the report was completed, and the recommendations were put forward. A number of them that you can see there in the bullet points. Nothing, as far as I'm aware, has been agreed to, so to speak. You can see at the bottom there, it's a long transition to the proposed arrangements, especially about the per milligram reimbursement, and require further investigation, and we'll see how that moves, if it does move into 2024. So there's a report with the government and it's got a set of recommendations. So at least they're moving that forward. I think one of the interesting ones, one of the other interesting ones is moving forward. I don't remember, did I have it on the other one? Let's have a quick look. Did I have it there? No, it wasn't on the. Oh yes, it wasn't there on the. It's a new one. So what the reason I want to talk about the National Hospital Funding Arrangement or Funding Agreement and the addendum to it is because it's going to expire in June 2025, and as part of the agreement, clause 21 for those who are legally and regulatory inclined, supposed to have an external review process, which started in February this year and supposed to be completed by December 23. So we've got 31 days left. And it's going to involve the states, the territories, the Commonwealth, and AHIPA. Again, we haven't really spoken much about AHIPA. That's an independent hospital pricing authority. But Minister Butler's appointed two, I think, very good independent reviewers. There's been a lot of external reports and comments given to them. Not easy to find. There's no collective area for this at the moment. The report is expected December 23. It's a draft. But I think from a reimbursement point of view, the addendum, the NHRA is a big agreement. It has a lot of things to deal with, but from a pharmaceutical / health technology point of view, one of the key pillars is funding arrangements for the new high-cost, highly specialised therapies, HSTs. And in this case, it's predominantly the CAR-Ts, but it can be some of the gene therapies as well, where they're being recommended through the MSAC committee, back to Sarah's sort of jurisdiction, even though they're technologies. And there's a reason why they're going through the MSAC and not the PBAC. And I think that's the interest that we have in that depending what comes out of this interim review about how it's working and so forth, maybe there'll be potential implications for CAR-T funding, but specifically in Australia, especially as the agreement ends in June 30th, 2025, which is a year and a half away, which in policy and funding pathway terms is not a long time, to be honest. So that'll be one to watch out for next year when we do the 10th annual presentation. All right. And so since I've led into CAR-Ts and cell therapies, I thought we'd share some background on what they are and some of the issues. Again, all publicly available information, nothing confidential or proprietary. Again, thanking my colleague Steve, who put these together for another presentation, and I've kindly stolen them legally. But the general approach to funding of CAR-Ts, it's a hot topic. Everyone wants to know what's happening. They still go through an HTA assessment and get another buzz. You know, our main way of looking at these therapies, they're not drugs, they're therapies. And it's a joint funding arrangement, which is the NHRA, which we just spoke about. So it's shared, interestingly, 50-50 by the states and the Commonwealths. And on the right-hand side, which is also unique, it doesn't really happen on the PBS or the NBS, which is a wholly federally subsidised system. And then you can see on the right-hand side, just people understand what we mean by CAR-T or this process that's involved. You can see there's multiple areas, multiple steps, and CAR-T infusion at the second from the bottom is really where the actual product is delivered. So the general approach to funding for CAR-Ts in Australia, and this is based on our reading of public summary documents of existing CAR-Ts, so we've gleaned from it. You can see, again, it's the HTA assessment, joint funding through the NHRA, and then there seems to be conditions for funding. So most of them seem to have a predefined limit of one CAR-T per lifetime or one CAR-T infusion per lifetime. Almost always there's a pay for performance based on outcomes in clinical practice. a collection of data through a registry. In this case, it's the bone marrow transplant, and then some type of outcome response at 12 months. No payment if the infusion is not received. So if the patient goes through these steps at the top here, and the company manufactures the product, if there's no CAR T actually infused, then there's no payment. And also if the infusion is unsuccessful, and usually there seems to be staggered payments, initial payment plus subsequent payments based on those pay-for-performance measures, which again, it's very different to pharmaceutical funding, PL funding, and MSAC funding, where there seems to be a one-off payment with rebates or discounts. So it's quite unique, and I think that's why it'll be interesting to see what this interim report actually does say, whether there'll be any detail or not. So just lastly on that, again, these are made-up numbers, just to illustrate the point of an example of how a pay-for-performance could work on those outcomes. So, if you're referred to treatment, you go through those steps, you're apheresed, but only 80% are infused, of patients that is. You get that first payment up front, maybe you get 40%. That's up to the negotiation powers of the companies with the Commonwealth. So the company would receive, say, 40% of 400,000 for that first infusion, and if they get the outcome, the second payment, they'll get the final or the remaining 60% if they achieve, say, 50% of a response. So you can see where we started at $500,000 for the product, and if you get a response, the per patient cost is $280. And obviously, if you get more patients responding at that payment too, you'll end up with more payment. So it's a good example of a pay-for-performance type system within the Australian healthcare / HTA system. Because Sarah and I collaborate and we know what we're talking about each other, I've stolen her slide from the earlier one. I've just made the dollar sign bigger because the PBAC has the highest cost recovery fees. I think they continue to be burdensome especially for the smaller companies or startups. We still don't have fees for MSAC, but I think they're coming. I think there was legislation ages ago as part of the Zimmerman review, was one of the only recommendation that's been put forward from the Zimmerman review, strangely enough. And I think, as we saw earlier, I've put there the PL has got the lowest fees because when you compare the numbers with the pharmaceutical side compared to the PL side and the drafts that we've seen for MSAC, you can see this is just an example of what would happen if you had a category 1, I'm not going to go into the detail, but sort of the most complex submission to the PBAC. You have a pre-submission meeting, which will cost you about 15 and a bit. Your submission fees are $252. And if you go try to list with a new deed of agreement, it's $111. So in addition to the cost of putting the submission together, the fees are $379,000 compared to the slide we showed earlier for the PL, which is about $5,000. So I'm sure the departments or the sections are talking to each other. So we'll see what happens with those cost recovery fees over the coming years. Hopefully Sarah and I are retired in the Bahamas by then, so we'll see. But that's a one-off. That means what I'm saying is that's a first-time successful submission. You can see on the bottom left-hand side, if you go back in for a resubmission, the fees are not that much cheaper, especially for a standard re-entry where it's going to cost you another $195,000 to put in a standard re-entry submission. So not to be underestimated when sponsors, it's a fun cost, but it's not to be underestimated, the cost of putting in a submission to the PBAC. So looking forward to 2024 as we wrap up the exciting webinar you've all been listening to. We have some people in the audience here with us live too. I won't mention the school, but we've got 2 Year 10 students at work experience, so they haven't fallen asleep, almost. They're riveted. We may have some future health economists or marketing people on our market access people on our hands. Anyway, so the HTA review, policy methods review, was again announced by Minister Butler. It's part of the Medicines Australia agreement with the department, the memorandum of understanding. There's a lot of work, a lot of papers to read, and I think a lot of us in that part of the world or part of the business is interested to see what happens. I think Medicines Australia is doing a great job in trying to link the HTA reform with the National Medicines Policy that's come up, and obviously the inquiry that's going through has gone through the House of Representatives, because it's all connected at the end of the day, and we're trying to get better access, more timely access for the patients who are in the middle of that Venn diagram you see. So I think we probably will spend a bit of time on this next year when we both during the year, but also at our update at the end of the year. So to finish off, last few slides, just some of the situational analysis, or again about what's going to happen. I mean, the 3 reasons to do the HTA review is, we're trying to reduce the time to access for those patients, for new technologies, and I think to Sarah's point earlier, it did have a focus on medicines, I think, but that is being redirected to gene therapies, including cell therapies, including medical devices, maybe not diagnostics, but definitely on the devices side. I think there's an understanding it should be broader than just pharmaceuticals. Again, we want to ensure that we don't let Australia slide down the list of launching products, so we want to be up there in the first, and keeping pace with new methodologies and policies and so forth. So, I mean, you see some of the timelines there. It's going to be, it's running now. There's a bunch of papers that have come out. I'm not going to review them all. It does represent an opportunity, though, for us as an industry to contribute, and we are contributing, and I think Medicines Australia is doing a great job doing that. The first round of submissions, they received 113 submissions, so I think that's shows the level of interest from the industry and from the public and from the medical community. So there's been a second round, been a bunch of discussion papers come out already. You can see some of them on the right-hand side. I won't detail them all. But the last 2 slides are just to show you the breadth and depth of what's happening and where you can dive in as you want to or need to. And so this is the department's calendars about what's happening at the timelines, and so we're sort of down there at the bottom there, October, November, about consultations and hubs and papers. And then there's 2 parts. There's actually the consultation plan, and then the research and analysis plan, which is a whole series of the papers we just talked about and reviewed. So I think there's a lot of work, a lot of discussions to be had, and I just encourage everyone involved in the space to try to devote as much time as they can, me included. I have not read all the papers, I will admit. It's quite a voluminous work, but I think it's important for our healthcare system to get involved and make sure we try to get the best healthcare system we can for health technologies, drugs, devices, cell therapies, and gene therapies. So I think we're just about on time. Thank you. Questions? And I think we have one. I can't see it. Yeah.
What happens when resubmitting an application that was originally rejected in PLMS?
Oh, that's a good question.
Do you want to just repeat it a bit loudly?
Yeah. So what, can you read out a question? What happens when resubmitting an application that was previously rejected in PLMS? which PLNS was the original online system for submitting a PL application. Look, again, you'd have to ask their department for advice, but I can't see any other way than submitting a completely new application. The reason being, if it's been rejected in the past, you're going to have to provide some sort of new information or, clinical papers or some new analysis to make them change their minds. And the only way to do that is going to be to put a new application in. Unless you want to engage, it depends why it was rejected. If you think it was incorrectly rejected, you could engage directly with the committee by writing to the MTAC, previously known as PLAC, and see how you manage that way. That's quite difficult, and you have to have a really good reason for doing it that way. Otherwise, you're just wasting their time. But I have done a few of those objections and have got them changed, but it's only if it's really egregious and they've clearly done something wrong. But if they've just said to you, we don't have enough clinical evidence, go back and we'll get more clinical evidence. There's no other way of doing it than putting a new submission in.
Thank you, Sarah. So shall we say our thank yous and goodbyes? You go first.
Thanks everyone for hanging in for a 9th webinar. But anyway, we'll post these slides and a video of just a video of the webinar. And if you want the slides, you can just email us and we will send you a PDF copy.
Indeed. Thank you very much. Enjoy the rest of the day, wherever you are. And may you, another question's just come in, which is great. Before we go, one more question, and then I'll just say festivities, Happy New Year, and one more question. So just give us a second and we'll read.
devices.
It'll just
Yeah, so what was the outcome of PL reform for drugs evaluated as devices? I'm not quite sure what you mean, if you mean like devices that elute drugs or yeah.
As devices on PL.
Can we take that on advice?
Yeah, just
send us Sarah an email. Yeah.
Some details and I'll try and help you out because I'm not
Indeed.
quite sure about what you're getting at there.
Awesome.
Yeah.
All right. One more time. Thank you.
There was another question, I think.
No, that was it. Yeah.
No, that was it.
Thank you very much and enjoy the rest of the day wherever you are. Thank you.